Hello, everyone. Once again, I want to thank you for your patience. We'll go on with the webinar. Very good evening once again to one and all present here. I want to welcome each and every one of you to this webinar on head and neck cancer in the Indian context. It's organized by the International Association of Oncology and our supporting partner, Biolex. On behalf of the International Association of Oncology, I would like to extend a warm welcome to the speakers and all you participants. I'm sure that this is going to be a very useful and informative session. I would like to brief a little bit about the organization. IAO, International Association of Oncology, is one of the renowned professional associations for medical oncology and life science professionals. IAO is a non-profitable professional association meant for research and development in the field of medical oncology and life science. IAO is an international forum for researchers, academicians, doctors, and practitioners for sharing knowledge and innovation in the field of healthcare and life science. IAO aims to bring together worldwide researchers and professionals and encourage intellectual development and provide opportunities for networking and collaborations. IAO delivers access to its members the industry's most essential technical information by organizing conferences, workshops, annual convention meetings, and provides networking opportunities both locally and globally. The conferences and events organized by the International Association of Oncology can be acknowledged as an ocean of knowledge, leading to the way for innovative research and strategies, empowering the strength by awe-inspiring the complications related within oncology. Next, we can listen a little bit about Biolex. Biolex Worldwide is a not-for-profit professional association which prominently promotes research and development. We at Biolex have brought a revolution in the field of worldwide conferences. Biolex conferences bring together professional wizards and leaders who have explored all avenues of the course of the field of life science and medicine. Biolex Worldwide conducts events worldwide, which helps in enhancing the skill set of the people from diverse industries and forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians, professional business figures, and so many more. Biolex conferences encourage better comprehensive understanding about improvements and progressions over the world through worldwide conferences with the speed of science and technology. We work with our motto of creating a better tomorrow by organizing conferences and creating a network which will help to grow a better tomorrow. So we could see a little bit about the need for this cancer. About this cancer webinar. The cancers that affect the regions of the throat, larynx, nose, mouth, sinuses, and also the salivary glands, thyroid, and other surrounding tissues are collectively called head and neck cancer. The symptoms of head and neck cancer can include, but not be limited to, a persistent sore throat, hoarseness, a lump in the neck, difficulty to swallow, and change in the voice. Like in many cancer treatments, the treatment for head and neck cancer options also depend on the type and the stage of the tumor, and it includes surgery, radiation, and chemotherapy. Globally, head and neck cancer accounts for 650,000 new cases of cancer and 330,000 deaths annually on an average. In 2018, it was the seventh most common cancer worldwide, with 890,000 new cases documented and 450,000 people dying from this disease. So now we know that why this webinar is so important. On that note, we could go on to the lectures that we've all been eagerly waiting for. And it gives me immense pleasure to introduce the speakers for today. First speaker for today is Dr. Sunil Humati, consultant oncologist at Ganga Medical Hospital, Coimbatore. His specializations are breast cancer surgery, oncoplasty, head and neck surgery, musculoskeletal oncology, including limb salvage, minimally invasive urogynec oncology. Sir has also received a lot of awards. A few to mention are Thomas Cherian Memorial Golden Scalpel Award for the Best Outgoing MCH, Surgical Oncology Student of the Year between 2016 through 2019. He passed out with distinction in medicine and surgery from Madras Medical College in the year 2010. Sir, we welcome you, sir. The next speaker is Dr. Krupa Shankar S., Director and Senior Consultant, Medical Oncologist, NSR Cancer Center, Visiting Consultant at Ganga Hospital and Vedanayagam Hospital. Sir graduated MBBS in 2008 from BMC Salem. His MD in General Medicine in 2013 from PSG IMSR Bogota. Sir finished his DM in Medical Oncology in 2018 February from Adyar Cancer Research Institute, Chennai. Apart from that, he also has a Master's of Health Sciences in Diabetology, Annamalai University, which is recognized by the Government of India, and he has a fellowship in palliative care, IAPSC certification. On that note, I would like to extend my warmest and my gratitude to the speakers, Dr. Sunil Humati and Krupa Shankar, on behalf of the International Society of Oncology, for taking your time to share your knowledge in this very important topic. We welcome and we thank you, sir. Now I have to take over the session.
Hope my screen is visible. Can you hear me, and is my screen visible?
Yes, sir. Yes, sir. We can hear you. Screen is visible too, sir.
So thanks for your nice introduction, and we'll go on with the webinar. There's already a delay. So today we'll speak about oral cancers, the latest trends and latest things that is happening, the surgical aspect of oral cancer. So as it has already been said, what is the need for speaking about oral cancer? Although both sexes combined, although in India the tobacco use in females are all little less, but still both sexes combined, and because of various reasons, the oral cancer has been the leading cause in males. And when males and females combined, it is going to be the second leading cause, and in females alone, it is going to be the fourth leading cancer. So that highlights the importance of today's webinar and what has to be done for that. So as we all know, the treatment, surgical treatment, is been quite standardized. That is, any patient presenting with any ulcer in the oral cavity will be investigated by taking an imaging, biopsy, and then surgery, followed by chemo or radiotherapy if it is a localized disease. In a metastatic disease, my colleague will be telling you what has to be done. So I'll limit myself to a localized oral cavity cancer. So this is how oral ulcer looks like. And we advise any patient having a non-healing ulcer for more than 3 weeks of time to come to us for further evaluation. So this gentleman had come to us with a history of 2 months of ulcer in the tongue, which is not healing. He had a history of tobacco usage, and he has sharp tooth. So he was further evaluated with an MRI scan to assess the depth of the lesion and a incisional biopsy from the edge of the ulcer, which showed to be a moderately differentiated squamous cell carcinoma. So the treatment is going to be wide excision of the lesion with the ultrasound, the MRI of the neck showed no significant lymph nodes. So the treatment is going to be wide excision of the lesion, and if there is less than 30% of tongue loss, you can still close the tongue primarily, and that is what was done. Wide excision of the lesion. Sent for frozen, the tongue was closed primarily. There will be little difficulty in mobility of the tongue, but with physiotherapy, with speech and swallowing exercises, it should get better. So, and although the neck nodes are negative or MRI, we do elective neck dissection because microscopic disease can be present in 20% of these patients. So we do elective neck dissection. So this is pretty standard. There's no deviation from these protocols. So when we look here, this is a post neck dissection photograph showing the common carotid artery. This is the carotid bifurcation where you can see the internal carotid artery, external carotid artery. This is the superior thyroid artery. This is the lingual artery. And this is the hypoglossal nerve. This is digastric muscle, posterior belly, tendon, anterior belly, mylohyoid muscle, hypoglossal nerve, the hyoglossus muscle, the spinal accessory nerve, and this faint thing here is the phrenic nerve. So this is how we clear the neck so that there is no micrometastasis in the neck. So once the histopathology comes, this was a T2 lesion, 2.5 centimeters, moderately differentiated, no significant neck nodes. So these with no high risk features like lymphovascular invasion or perineural invasion. So these patients will be kept on follow-up every 3 monthly for the first 2 years and 4 monthly for the next 1 year and every 6 monthly for the next until 5 years and annually thereafter. So this patient has completed around 4 years of follow-up and is doing fine. So this is pretty much standard treatment for any oral malignancy. So what is upcoming in all other sites is the sentinel lymph node biopsy to avoid unwanted prophylactic neck dissection. That is, in an N0 neck, the chance of the neck node being positive is only 20%. 80% of the time we are doing a prophylactic neck dissection unwantedly. So is there any way in which it can be avoided? Is already we know the established sentinel lymph node biopsy, but before this era we were doing a neck dissection based on the depth of invasion for especially for tongue lesions. If the depth of the invasion on a frozen section is going to be less than 2 millimeters, then we tend to avoid elective neck dissection. Anything more than 4 millimeters, we always do a selective neck dissection, which involves level 1 to 4. And anything between 2 to 4 is equivocal. We decide on case-to-case basis. But once the sentinel lymph node biopsy is done, all N0 necks, when a biopsy-proven malignancy, has to undergo sentinel lymph node biopsy and further treatment based on the reports of the sentinel lymph node. So there are 3 ways of doing a sentinel lymph node biopsy. One is a blue dye, another known as a technetium 99 nanocolloid, and the recent one is the indocyanine green. Although the mucosal injections and the study on the neck nodes for indocyanine green is not yet standardized, but the technetium 99 and blue dye are all standardized, and multiple studies have been happening from the year 2000 and till now. So what we do usually is inject technetium 99 nanocolloid less than 16 hours. That is 1 day. Usually it's the day prior to the surgery, the evening prior to the surgery. And we take a CT scan at 15 minutes, 30 minutes, and 1 hour interval. Since the CT scan is a 2-dimensional imaging, we always do an anterior, lateral, and a posterior views. Along with that, isosulfan blue dye of 1% is also injected at the time of surgery. Any node that shows a background activity of more than 3 times the background activity will be considered significant and taken and sent for frozen section. This is how a CT scan looks at 15 minutes, 30 minutes, and 1 hour. So at 15 minutes, you can see the big head is where the primary is, where we have injected the dye, and this is a level 2 node and a level 4 node on the CT scan. So then what we do is we use a gamma probe to pick up these nodes. These are various, and the node is excited and sent for frozen section. So the frozen section, they analyze it further and tell us whether the node is positive or not. Based on this report, we can go ahead with a complete neck dissection or not. Although so much of studies and so much of research has happened in this setting, but still it is not popular. So we need to understand why the sentinel node biopsy in oral cancer is not yet popular. So anywhere in the oral cavity, patient might be a tobacco chewer, might have had trismus, or might have a limited mouth opening, might have a difficulty in tongue movement because of a lot of other reasons. So technically injecting peritumorally in a patient with oral cancer is slightly difficult compared to other sites like breast cancer or endometrial cancer or melanoma, where it has been completely established as the standard of care. And the second thing, because we don't use an ICG is not at a standard, the spatial resolution of technetium 99 centigram is not so great. So we might have to use a CT with an uptake study as well, overlapping with uptake study as well. So the third thing is, if you have a lesion in the floor of the mouth, there the level 1B node is very close to the floor of the mouth. So there might be shine through effect. That is, you might get Geiger-Müller counter showing high counts in the level 1B, but it might not be the significant sentinel node. Since we use a nanocolloid, it floods faster, so there may be skip sentinel nodes in level 4. Resection of primary setting in injection of blue dye makes the field a bit messy and makes things difficult for us. And this is mostly we are identifying micrometastasis, which without help of cytokeratin or serial sectioning, which might be difficult when we do a frozen section alone and might miss micrometastasis at the early stage. So this is category 2A recommendation, still not category 1 recommendation like other sites. Maybe once ICG comes in, maybe once the technical difficulties are addressed, this might be the way to go further in the future. So because in Indian setting, there are a lot of patients with oral cancers with lack of time, lack of expertise doing free flaps. The standard reconstruction for the last 2 decades has been a pectoralis major myocutaneous flap. This patient had a tongue cancer, which was close to the mandible, where the mandible segment of the mandible was resected, and he was reconstructed with a tissue from the chest, which is a pectoralis major myocutaneous flap. Main disadvantage is that he doesn't have a bony reconstruction. He has only soft tissue reconstruction. So there's half of the mandible, you can see it is swing to the opposite side because of the pull. And the problems with this, the most common reconstruction is that no bone, it is only soft tissue. There is a lot of mandibular swing, resulting in loss of occlusion. That is, patient will not be able to clench its teeth even on the normal side because the mandible is already deviated. So the upper tooth and the lower tooth are not going to be in line. So this results in eating, speaking, and swallowing difficulties. And at last, we all are worried about a good cosmetic outcome as well. This will result in facial asymmetry. So what we have got to offer is something called, the most common thing that gets removed in oral malignancies is a mandibular bone. So without the bones form the facial skeleton, bones give a rigid support for a lot of things. So without that, we won't get a good functional physiological outcomes. So what has happened in this field is that is a 3D planning, because we can get a bone, but we can't get a bone that is exactly in the shape of the mandible. So what we do is a 3D planning. That is, if we decide this part of the mandible is going to go, we get a CT scan at 1 millimeter cuts, and the bone that is most commonly used is a fibula. So that area is also imaging is done with less than 1 millimeter difference. So once we say this part of the mandible is going to go from this tooth level, the cut is made in the computer with a 3D model, and the fibula bone, which is a straight bone, that is going to be curved and accommodated as like the mandible, and it is symmetrized either with the ipsilateral side or the contralateral side. So this is how it is done. So this fibula had to be cut at 2 places to make into a new symmetrized mandible. So these are the cutting guides or the whatever. This is going to guide us, and this is going to save us a lot of time, because without this, getting an exact shape of the pre-existing mandible is going to be extremely difficult. So I'll be showing a few examples of how this was done. This was a lady with a huge mandibular tumor, for which her entire hemimandible has to be removed. So once we did a lip split, and that's the tumor on the left side, and that's the cutting jig that has been pre-contoured and which was autoclaved and brought onto the table. So once the tumor is removed, this is a huge defect that has to be replaced with the bone, soft tissue, and the mucosal lining as well. So that's a tumor that was excised in toto. You can see the tooth, you can see the bone, and a lot of soft tissues attached to the tumor. So we have taken the fibula bone from the leg along with its blood supply and the skin, which is going to be the mucosa for mucosal lining for us. So this bone is a straight bone. It has to be curved to the shape of the mandible. So this is a cutting guide which is fixed to the bone, and it is cut into 3 pieces. Now it will be placed on the patient's native mandible and will be fixed with the plate and a screw. So this is a post-operative outcome of the patient who had a huge tumor of the left mandible. Almost the symmetry is maintained, and since the mandible is there, she can get her tooth back. We can put the implanted tooth and she'll be leading a near normal life. So this is another example where we had to remove the central part of the mandible. Apart from that, sometimes patients with head and neck cancer come back with recurrences, to multiple recurrences even after a fibular reconstruction. This is one such patient who had come with the 3rd recurrence, and he has lost both his fibular bones and a huge intraoral lesion, which is adherent to the skin surface. So we had to remove the entire left hemimandible reconstructed part mandible along with the infratemporal fossa and part of the tongue. And there were quite a lot of challenges in reconstructing this patient. We had to use a huge flap from the thigh without a bone. So this was a long-term outcome of this patient. The flap has settled well. He's doing extremely fine even after his 3rd recurrence. So this patient had an ulcer involving her entire tongue, for which a total glossectomy, a segmental mandibulectomy, and a free flap reconstruction was done. And as following speech, everything was rehabilitated. So this are the latest advances: single flap, dual flaps, flaps in the recurrent patients, 3D reconstruction. That's what all happening in the surgical context of a head and neck cancer patient. So this is for oral cancers. Sometimes when the cancers are deep in the neck, initially what was done was a lip split, a mandibulotomy, and then reach the throat, and a surgery was done. With the advent of endoscopes and robots, now we can go through the oral cavity and approach any lesion in the throat or in the parapharynx and these areas. So I'll be showing you a short video where a parapharyngeal mass was excised endoscopically with avoiding any neck incision or lip split or a mandibulotomy. So that's going to be.
Hi everyone. Today we will be looking at how to do a transoral.
So that's a mass in the
MRI. It's approximately.
So that's a mass in the. Sorry. So that's the mass which we can see on the parapharyngeal space on MRI, huge mass. So what we'll do is we'll be injecting adrenaline in the parapharyngeal mucosa, and the incision is being placed on the pharynx. So incision being marked, That's an endoscopic view inside the mouth at the level of the base of the tongue. So the mucosa is incised. The parapharyngeal muscles are being cut. Once the muscles are cut, we'll be looking at the tumor. The second layer of the parapharyngeal muscles. So now we can visualize the tumor after cutting the deeper layers. The white thing which you are seeing is a tumor. Once this has been cut, the tumor will be, so retraction stitches will be put. To provide adequate traction, and the tumor will be separated in block in toto from the surrounding structures with help of combination of sharp and blunt dissection. You can see a huge global swelling. We're taking furthermore traction stitches. The tumor is separated from the surrounding structures with the help of suction, elevators. You can see the tumor slowly coming out. That's the base of the tumor, still attached. Violating it and cutting it. So that's the bed, huge defect, and that's around 6 centimeters tumor. Now the mucosa is being closed, single layer end block with endo-oral sutures. Without advent of robotic or endoscopic surgeries, there would have been a very morbid surgery in an 80-year-old lady, and the final biopsy report came out as pleomorphic adenoma. That's the suturing. That's 3 weeks later how the wound has healed. Thank you. So thank you, and that's my WhatsApp and mail ID for any further queries. Thanks.
Thank you so much, sir. I'm sure the lecture was very informative for everybody with all the image, and I think it was very well explained too, sir. Thank you so much. We have a bunch of questions, sir, in the Q&A tab. Would you be, can we take that now?
Hello.
Can you hear me, sir?
Yeah.
Yes, sir. So we have a couple of questions in the chat box, sir. Can we take the questions now?
Yeah.
Okay, sir. So the question, I think the first one is, okay, just give me a minute. Okay, so that's the question goes like, more extensive type of surgeries include free flap surgery, where tissue is transplanted from elsewhere in the body. This can be bone, skin, or muscle, or a combination. Which technique do you prefer?
So you always like to replace a like tissue with a like tissue. See, like I said, you need to replace what has been lost there. Like if you lose a mandible, it is always preferred that you have some bone, so that in future it gives you a lot of symmetry. It prevents swinging of the opposite side of your mandible, and you can always have a tooth later date. So if you don't replace the bone only, you because of some reason you're going to replace only the soft tissue, then it is going to
Oh,
be very
oh,
difficult for speech, swallowing, and a lot of things.
ah,
So
okay, okay.
based on what is lost, like there will be the bone that is lost, there will be some soft tissue that is lost, and there will be some mucosa that is lost. So based on what is lost, we prefer to select the best combination that can be used to replace that for that particular patient.
Thank you, doctor. The next question is, okay, so the question is quite descriptive. So I will just read the whole thing. How long does it take to recover from oral reconstructive surgery? The post-op stage in all reconstructive surgery depends very much on the extent of the surgery. Simple reconstruction such as bone grafting, sinus lift, or dental implants can be done as a day case procedure, and the recovery time is minimal. More extensive surgery can require a prolonged stay in hospital with some period of extensive care and anywhere between 5 and 15 days in the hospital. The patient will undergo intense rehabilitation from different members of a team, including speech and language therapists, physiotherapists, and dietitians to help relearn the normal functions. Any suggestions?
Yeah. So why extensive surgery first? I'll tell why extensive surgery first. So thing is, although there have been a lot of research and a lot of techniques that came in as in a brief period, like dental implants, bone grafting, tissue grafting. Not because you need to understand in a malignancy patient, if it is a trauma or something else, it's okay. But in a patient having malignancy, all these patients, most of them would undergo something called as radiotherapy. So, and our body's adaptation to any of the foreign tissue is very, very, very minimal. So there is high chance of infection with dental implants or any bone grafting and all those things. And their resistance to radiation is extremely low. Yes, agreed. These patients have a long surgery, increased prolonged hospital stay, and increased rehabilitation. But although these people undergo all this, it is worth taking that extra effort and getting the right reconstruction done at the right time, because these people will need to undergo radiotherapy, and these people, if they have any implants, there are long-term chances that these implants or bone graft, whatever that is done simply, can go in for osteoradionecrosis, implant exposure, and very long-term problems. To reduce all this time constraints and everything, there are technical advances in doing these reconstructive surgery, such as, like I showed you, the 3D modeling, which helps us reduce approximately around 30 minutes to 1 hour during the surgery. And there are couplers that are helpful to anastomose these small minute vessels that can shorten the time. And we also follow the ERAS protocol, which is early recovery protocol for all the patients, so that they have the shortest time in the hospital. And furthermore, to avoid a tracheostomy, we keep them with a nasal tube overnight ventilated, and tracheostomies are done only as and when required. So we have narrowed down all the morbidity related to the surgery as much as possible, and these technical advances are still happening. So we might be able to give a better result in a shorter span of time as well.
Thank you so much, sir. We have a question from an anonymous attendee. The question is, what are the main causes of oral cancer?
Okay, so the main cause of oral cancer still is going to be oral tobacco. In non-tobacco users, we have human papilloma virus, which can cause more of oropharyngeal cancer. Apart from that, the more common cause is going to be sharp tooth. See, repeated trauma at a certain point of place can cause oral cancer. Along with that, alcohol and spicy foods, and all this can lead to oral cancer. The most common cause is going to be tobacco.
Thank you so much, sir. Also, Dr. Abhishek Banerjee has requested Dr. Sunil Kumar's email ID. Sir has put it in the slide, so you can probably just make a note of it and
Can you see that slide still?
Yes, it's still on. The phone number and the email ID, it's still on. Okay. So there's one more question, if we can take the last one. It's from a person called Sheetal. Metastasis site of oral cancer.
So the first most common metastatic site is going to be the neck nodes. If you think that's going to be the regional level, then it's going to be the lung. So the most common site is going to be lung.
Thank you so much, sir, and thank you for the wonderful presentation and for taking the time to answer all the questions very patiently. Thank you so much, sir. On that note, I would like to invite the next speaker for the evening. In just a moment. I believe there's just some kind of a technical issue.
Yeah, Pauline.
Yes, ma'am.
There is a technical issue with this. Sir is rejoining again. Just 2 minutes.
Okay, ma'am. Sure.
Yeah. Krupa Shankar, sir, can you hear us?
Hello, am I audible? Are you able to hear me?
Yes, sir. Yes, sir.
Yes,
You're audible. You're audible. You're audible now.
Okay. Sounds good.
Yeah.
I think there was a small technical glitch. I wasn't able to hear anything, but now I'm able to hear you guys.
Yes, sir. Yes, sir. Sure, sir.
So I'll just share my screen and we'll get started right away.
Sure, sir.
Well, hope my slides are visible and I'm audible.
Yes, sir. The slides are visible. We can hear you too.
Great. Okay. So very good evening and a warm welcome to everyone. And at the outset, before I begin, I'm going to have to take this opportunity to congratulate for this wonderful academic initiative and also thank you for the opportunity. So I'm going to take you through the current consensus, challenges, and controversies when it comes to the management of locally advanced head and neck squamous cell carcinoma. So we know, obviously, we're looking at early stage disease and then local regional disease as well. And when it comes to local regional disease, what we're going to basically look at discussing today is the difference between potentially resectable and unresectable disease. And how do we look at? Because we know definitely that makes a huge difference as far as the prognosis is concerned. Because for potentially resectable disease, you're talking about a 5-year overall survival close to 40%. And for unresectable diseases, it drops down to around 10 to 20%. So that's the sort of difference that can make as far as resectability is concerned. So how do you then decide between surgery-based treatment versus radiotherapy? Well, definitely if the tumor is operable and resectable and if the patient is willing to go ahead with surgery, I think patient preference also plays a key role here. Then definitely surgery becomes the cornerstone of treatment. But if the patient, the tumor is resectable or operable, or the patient declines surgery, patient preference or organ preservation, then you're looking at radiotherapy-based treatment to be primary modality of treatment. And also, the tumor site also will definitely sway your decision as far as your decision-making process between surgery and radiotherapy is concerned. We all know that for any oral cavity tumors, resectable disease, obviously primary surgery is always the cornerstone of treatment. Whereas for larynx, oropharynx, and hypopharynx, you're looking at organ preservation as definitely as an option. And then you're looking at doing concurrent chemoradiation. We'll get to the partner of agent as far as your concurrent radiosensitizer is concerned. We'll get to that a little bit later on. So what then are the indications that we regularly look at as far as neoadjuvant chemotherapy or induction chemotherapy in our institutes? And how do you look at defining resectability and operability? Like we know we talk about resectable disease, and then we're talking about borderline resectable, and then we talk about inoperable disease as well. And I think it's very important for us to have an MDT discussion right up front so that we always segregate the patient into any of these three categories. So let's look at probably a few examples. One is a left anterior two-third of trunk which is crossing the midline for about 1 centimeter, and then buccal mucosa with a 3 centimeter neck node, and a paramandibular lesion which is not invading the mandible. Would you look at using neoadjuvant chemotherapy in any of the above scenarios? Well, I'll show you the data as we move along as well, especially as far as mandible preservation is concerned, and does induction chemotherapy or neoadjuvant chemotherapy play a role there? So these were trials looking at role of induction chemotherapy followed by surgery as opposed to only surgery. Here they looked at using a triplet, which is DOSI, cisplatin, and 5FU. And again, as you can see here, clearly no difference in the local regional recurrence, distant recurrences, or in the overall survival. This was yet another phase 3 RCT looking at oral cavity squamous cell carcinomas. Again, here they used only a doublet cisplatin plus 5FU and then took them up for surgery. Again, no difference in local, regional, or distant recurrences and overall survival as well. So then that again brings us to the next part of our question segment, which is, well, we know if at all we do use induction chemotherapy, do we still stick to the pre-neoadjuvant chemotherapy imaging status as far as deciding on surgery, or do you go by only the current tumor extent after induction chemotherapy? And again, we know that somebody who's chemosensitive, probably you look at identifying them as the responders and non-responders, and probably somebody is going to have a better prognosis. And then again, there is always the risk of progression in resectable disease. If you do want to do induction chemotherapy in those patients, you're actually missing out on an opportunity of a completely curative intent of treatment. And again, what about the role of neoadjuvant chemotherapy in mandible preservation? I'm going to take you through that. So this was a trial that was again done at Tata Memorial, and they published this as well. Phase 2 trial looking at mandibular preservation, especially when they did neoadjuvant chemotherapy. And what they did find, I'm just getting quickly to the conclusion, is that they used a triplet here, DOSI, cisplatin, and 5FU, and they were able to preserve the mandible around close to 47%. That's approximately 50% of the patients who upfront had either mandibular invasion or were at a risk of having to undergo extensive surgery involving mandibular resection. So, well, that's pretty promising data, even if it's albeit only phase 2 data, but again, Indian data. And again, this is yet another data looking at oral metronomic chemotherapy as a component of preoperative therapy in resectable oral cavity squamous cell carcinomas. This is again from my good friends Praveen and Manu from MCC, Malabar Cancer Center at Talasheri. So again, what they looked at, because of the large volume centers, there's a long waiting time for all of these patients. So what you you really want to offer them at least some sort of pre-op oral metronomic chemotherapy to see if you could actually bridge the gap until surgery. So what they did offer them the pre-operative metronomic chemotherapy, which consists of methotrexate, celecoxib, and erlotinib. And what they did realize was predominantly most of them either had a response or a stable disease. There were very few people who actually progressed on this. And which is why probably in an Indian scenario, especially if you're running out of patients, or if you have a lot of waiting time for your patients, then this is definitely a feasible strategy worth considering. So then let's look at neck dissection and how do you manage the neck? Well, if it's clinically node negative, then you're looking at doing an ipsilateral elective neck and nodal dissection. And again, if as far as elective contralateral neck dissection is concerned in a clinically N0 disease, if you have a tumor which is crossing the midline, or if it's the floor of the mouth, then you're looking at probably offering an elective neck dissection contralateral as well. But if it's a clinically node positive disease, then you're definitely looking at doing a contralateral neck dissection. And again, what can you do a PET-based surveillance apart from doing an elective neck dissection? Well, there was a PET neck study which looked at addressing that question. And again, you had to do a PET at 12 weeks after completion of concurrent chemoradiation. And then you could decide based on if there is any uptake in any of the nodes, whether to decide between neck dissection versus no neck dissection. If there was no uptake, or if you had a mild uptake and the node size was less than 1 centimeter, you could still keep them on close follow-up by repeating a PET scan at 12 weeks. So that's how the current consensus is on that. And what about the role in inoperable disease? Well, this is pretty straightforward. I think, on all of these situations, we'd probably look at, for example, a tongue with a 6 centimeter cervical lymph node, which is completely fixed and encasing the vessels, and buccal mucosa with intracranial extensions. We would definitely look at trying to offer them neoadjuvant chemotherapy or induction chemotherapy to look at converting them, or conversion therapy. So what then would be the best approach? Would it be just neoadjuvant chemo followed by concurrent chemoradiation, or definitive chemoradiation, or would it be palliative chemo? So these were trials looking at induction chemotherapy, paradigm study, and then the DECIDE study as well, looking at triplet TPF followed by concurrent chemoradiation versus definitive chemoradiation. Well, there was no difference in survival, no difference in PFS and the OS as well, and this also mirrored. So why then are we seeing this negative results? So number one, remember that these trials were basically designed in the US, and also all these trials did not complete their accrual. So there was very poor patient accrual, and they actually stopped the trial early as well. And so remember that, as far as our population is concerned, we get to see a lot of more patients with locally advanced disease, and we rarely get to see people with early stage disease. So again, so that really matters as far as, that's why we say, obviously, we're looking at our own data, and we will need to all collaborate together to look at whether there's a role of neoadjuvant chemotherapy in this subset, which I strongly believe is, especially if there's patients inoperable or unresectable, that definitely becomes an option. And again, so this is just to highlight on the paradigm and the DECIDE studies and the SWOG study. All of them look at the target and look at the poor accrual. They did not a complete accrual, and which is why all of them ended up being negative studies. But that doesn't get discussed. We all talk about there's no data, and then it's all negative data, which is why it's very important for us to pertinent to look at Indian specific data. Albeit, okay, this is again data from TMH, retrospective data, but close to 700 patients. And look at that, around the response rates go close to 45%. And all of them have underwent surgery as well. And especially if you had surgery, then your median survival went up to 19 months as opposed to 8 months of patients who did not have surgery. So yes, we do have the data, especially from Indian centric centers like Kidwai as well. Again, this was retrospective data in T4B disease, looking at doing 2 to 3 cycles, resectability around 20%. And again, the median overall survival much better in patients who had surgery versus no surgery. McKenzie, well, this is probably the gospel as far as concurrent chemoradiation is concerned. One of the largest trials done, and this meta-analysis as well. So concurrent chemoradiation definitely superior to induction chemotherapy is how they concluded as far as locally advanced head and neck cancers is concerned. Well, yes, but then again, let's look at it a bit more in depth, or let's dig deep into it. Look at the number of patients who actually underwent induction chemotherapy. So, this was not powered adequately enough to answer the question of whether induction chemotherapy would actually be good enough. And that's why probably, definitely, yes, concurrent chemoradiation is here to stay. We're not going to debate that or going to destroy that. But what we actually have a point to make is that probably in a select patient, probably borderline resectable or unresectable disease, absolutely induction chemotherapy does definitely have a role. So if there's one study which is trying to answer all these questions, it is this HNN07 trial, which is looking at basically the randomization was between induction, was no induction, and then induction followed by chemoradiation, which is platinum or cetuximab with radiation. So it's probably trying to answer the question of does induction help, and number two, what would be the radiosensitizer of choice? Should it be cisplatin or cetuximab as well? And interestingly enough, if you look at this trial, induction chemotherapy did improve overall survival as opposed to not having any induction chemotherapy. And you can see that this was both statistically and clinically significant as well, close to 2 years improvement, 54 versus 30 months. So I think, that's when I said, it just depends on how you want to look at the data and how you interpret it. And again, when they looked at just cisplatin as a radiosensitizer as opposed to cetuximab plus RT, you can clearly see that there was a role again with cetuximab as well, albeit in patients who were platinum ineligible or even patients who were borderline fit for 3 weekly cisplatin, and where you had to end up giving the weekly cisplatin, then cetuximab definitely does remain an option. What about a technically unresectable disease? Well, I think, we'll look at defining what technically unresectable disease is. And in unresectable disease, we know chemoradiation about 10 to 15% long-term survival, but then neoadjuvant chemotherapy, you're talking about converting around 40% to 50% towards surgery, and the long-term survival doubles to around 30%. Rate of R0 resection, close to 60% of the triplet and 40% of the doublet, just TPF or PF, platinum and 5FU alone. So these are the indications which even our Indian-centric data looks at. So if you have edema up to the zygoma, tumor extension up to that, or disease reaching up to the hyoid bone, or high infratemporal fossa involvement, or extensive skin involvement and valvular involvement. So if you have any of these indications, then you would definitely justify it in offering induction or neoadjuvant chemotherapy in these situations. And again, if you look at the randomized trials, looking at doublet versus triplet, we know we've all heard about the TAX323 and the TAX324. And we know that, yes, that's how probably induction chemotherapy made its role. But then, the TAX323 also had carbo plus RT as part of it after induction as well. So that's something which needs to be considered. And again, I think the key challenges are in actually delivering TPF, because we all know it's a very toxic regimen, especially if how do you do it? Would you want to do it in 5 days or 3 days? And then DPD-assay and testing, are people actually routinely getting a DPD-assay testing done? And bolus versus infusional 5FU and admissions, and then close OPD monitoring, then you'll have a central venous access and an infusion pump, and then you'll have to look out for febrile neutropenia, dysalkylatemia, and all of those adverse events as well. So interestingly enough, this was again data from Tata as well, where they looked at the incidence, and in patients who had toxicity, related to 5FU, the incidence of DPD was close to 30%. It didn't drop down to 5 to 10% in the overall population subset, but especially in patients who had a toxicity, 1 out of 3 ran the risk of being DPD deficient. So I think that's probably a food for thought. Probably should you offer DPD testing? And then again, what about the role of a doublet or oral metronome chemotherapy with Paclitaxel and carbo? Any takers for that regimen? And what should be the ideal number of neoadjuvant chemotherapy cycles? And surgical morbidity and mortality, would that actually change or influence your decision-making process? And what should be the adjuvant chemo partner with RT? Let's look at answering those questions. Again, yet another Indian-specific data from TMH looking at administering neoadjuvant chemotherapy with Paclitaxel carbo along with oral metronome chemotherapy, which was methotrexate, celecoxib, and erlotinib. So it was basically a 5-drug regimen. But again, it seemed to be safe and tolerable as far as looking at giving even these 5 drugs together, and the overall estimated PFS and OS were comparable at around 1.5 years or 18 months to be exact. So I think, yes, there is a role. You could probably, if you have a patient who's fit enough to have all of this Paclitaxel carbo along with methotrexate, celecoxib, and erlotinib, well then, yes, does remain an option, especially in Indian patients. This is the TAX324 data, as I was talking about earlier here. Randomization was within doublet versus triplet, followed by carboplatin with RT and showing. So that's how we knew it. Well, let's look at the current ASCO 2022, where this was presented again, comparing docetaxel platinum versus again doublet versus triplet as neoadjuvant in technically unresectable oral cancer. And again, the same criteria was used, especially zygomatic involvement or involvement up to the hyoid. That was taken to define borderline unresectability. And the randomization was between docetaxel cisplatin versus docetaxel cisplatin and 5FU. So the 2-year survival definitely, as you could see here, definitely there was an advantage with the triplet over the doublet, albeit this may not have been statistically significant as far as the overall survival is concerned. But the PFS was definitely better, and this was significant as well. And as far as adverse events were concerned, definitely higher in the triplet arm as opposed to in the doublet arm. And it did improve survival, but at the cost of increased toxicity. So what about adjuvant chemoradiation? I know we're going to talk about preferred technique and then the area to be covered, neck nodes. What about covering the contralateral nodes? And post-neoadjuvant chemotherapy, does your RT field actually change? And also, does it also change based on the type of concurrent chemo or the targeted agent that can be used? We always talk about the RTOG and the ORTC trials, which are the largest randomized trials done in this setting, and they used 3-weekly cisplatin. And we know that the data is pretty strong as far as local regional control on DFS was concerned, even though the overall survival wasn't statistically significant. So there's a few differences in the criteria as far as eligibility for adjuvant chemoradiation is concerned. RTOG probably selected patients much more who had only margins or extracapillary extension for adjuvant concurrent chemoradiation, and 2+ positive nodes for adjuvant radiotherapy. Whereas the ORTC criteria looked at even anybody in stage 3-4 disease or level 4 or 5 positive nodes perineural invasion on LVI as well. So all of those were criteria for the ORTC. And again, a risk stratification, this is something that came up as well. If you had a favorable risk or a low risk, then your dose of radiation would be dependent on that as well. Intermediate risk and the high risk as well, 60 to 66 gray in the adjuvant setting. And what about the chemotherapy regimen in the adjuvant setting? Should it be 3-weekly or weekly? I think that's something that we've always debated on. So I'll quickly take you through that data. Again, Indian data, again from Tata Memorial, where they looked at weekly versus 3-weekly. And again, I think this was very interesting because the editorial says high doses cisplatin still lives on. So just because probably this is Indian data, I think we shouldn't be disregarding that shape. So again, this was the data. The randomization was within 30 mg per meter square versus 100 milligram per meter square in the adjuvant setting. Well, they could not prove non-inferiority, but the compliance was pretty even, and the median cumulative doses of cisplatin was reached in both the arms of more than 200 milligram per meter square. But again, as I was telling you earlier, they could not meet their primary endpoint of showing non-inferiority of the weekly versus the 3-weekly regimen. So, and what like any trial goes, obviously this trial also had its own limitations and criticisms. Again, the dose of cisplatin was criticized. Why should it have been only 30 milligram per meter squared? And then again, remember that it is not a weak comparator arm, because even in the weekly arm, the cumulative dose, more than 85% actually went on to reach the cumulative dose. But it was still, the cumulative dose is still more higher in the 3-weekly arm. So we always claim that it's more toxic. But again, the dose reduction and treatment discontinuation rates in both the arms were similar. Again, another criticism was that around 87% are only oral cavity cancers. But then again, that's more of a reflection of the real world Indian data, even from GlobalCan 2020. And again, if you look at the results, whether it's applicable to HPV negative subsets, remember that the incidence of HPV positivity in India is only around 15 to 20%. It's not as high as in the Western population. And again, primary endpoint of local regional control was in favor of the 3-weekly arm. Secondary endpoints, well, you don't need, because they were not powered adequately to answer those secondary endpoints. So I think the reason for that debate is, again, the Japanese study, the JCOG 1008, which looked at weekly cisplatin. Remember, this was a phase 2/3 study and did show non-inferiority of weekly versus 3-weekly. So this is how it actually read out. Look at the 3-year overall survival and the recurrence-free survival. Not only, remember that it was a phase 2/3 and it was designed to show non-inferiority. But like you always say in statistical parlance, you can use a non-inferiority study to actually show superiority as well. You can't do it vice versa. And so, but then, remember, looks can be deceiving because there are limitations with the Japanese study as well, the JCOG 1008. Again, we know that there were imbalances in the treatment group with a lot more patients in the 3-weekly cohort having an unfavorable prognosis. Median cumulative dose was still higher in the 3-weekly cohort. And again, we only have a follow-up of only close to 2 years. So we don't know about long-term toxicity. And again, remember that weekly cisplatin, you'll have to hydrate them weekly. So if somebody's got volume overload or if somebody's got a hard cardiac issue, then it becomes a challenge then. And remember, the real-world completion rates and treatment interruptions are also another thing to actually focus on. So what does NCCN say? So nothing really has changed until then. But now NCCN has recommended even weekly cisplatin in the adjuvant setting. But in the definitive setting, 3 weekly still holds good. And I'll show you the data for weekly cisplatin in the definitive setting as well, Indian specific data. So this is again yet Indian specific data from AIMS Delhi, where they looked at non-inferiority in the definitive setting. They called it the concert study. And again, they were able to show non-inferiority of the weekly versus 3 weekly regimen. And so probably, now we're moving to that sort of stage where we could look at doing weekly cisplatin along with radiation even in the definitive setting as far as Indian context is concerned. Well, again, this is something that I've always argued against. I've said we have criteria to define cisplatin eligibility and ineligibility. We don't have criteria to look at defining between weekly eligible or 3 weekly eligible. And we don't have that sort of criteria yet. You're either fit for cisplatin or you're not. In between, you could actually look at either using cetuximab. Well, again, this was yet interesting data where they looked at docetaxel as a radiosensitizer in patients who were non-fit for cisplatin, presented at ASCO 2022. We know that all of this have been tried in phase 3 trials, cetuximab, carboplatin, hydroxyurea, and paclitaxel as well. So, can cetuximab be used for everyone, instead of cisplatin? Well, I'll show you the data, albeit only phase 2 data. Remember that, if you look at this trial, phase 2 data, the adverse events were actually much higher in cetuximab arms versus cisplatin, and even the discontinuation rates and need for dose reduction even being higher with the cisplatin. Well, it did show that it did increase the toxicity and the efficacy was similar, which is why cetuximab should not be used for everyone and only should be used for cisplatin ineligible patients, especially if you're looking at organ preservation. Well, what about nimotuzumab? I know this is yet another very popular molecule, Cuban molecule, but again, unfortunately, not many takers, or at least I strongly believe that as a single agent, what activity does this molecule actually hold? It has a stronger binding affinity towards the EGFR, and that's how it's been propagated. It's approved in India, but not FDA approved as well. So this was the Cuban study which led to the molecule being looked at patients who are not fit for concurrent chemoradiation. And again, they looked at patients who are not fit for cisplatin and they used nimotuzumab Zati. So this was again data from called the BEST study from Idwar, where they looked at patients with advanced head and neck squamous cell carcinoma, nimotuzumab plus concurrent chemoradiation. And as you could see, the response rates were higher, overall survival was also much better. But remember that this is phase 2 data. Well, then came the blockbuster data again from Tata, phase 3 data looking at weekly cisplatin in combination with nimotuzumab as opposed to only cisplatin with RT. And well, remember that again, when you look at going to the subset analysis, oropharynx was 50%, hypopharynx was close to 20%, larynx 50%. So that's how they looked at grouping these patients. And remember that the number of patients who actually went on to complete more than 7 cycles in the weekly cisplatin was more than 80%, 85% to be exact. So that was one of the criticisms of the study, because they themselves in their prior studies had proven that weekly cisplatin was not, they could not prove non-inferiority to 3 weekly cisplatin. So why then do you have to use 3 weekly cisplatin? And if you use 3 weekly cisplatin, could you still use it along with nimotuzumab? So those are still unanswered questions. But if you look at it, it did show an improvement in EFS and in the local regional control as well. The overall survival data was also slightly better, but then this was not statistically significant, even though it was numerically significant. So that brings us to, what about using docetaxel as a radiosensitizer if patient is not? Because this was one trial was very unique because they looked at only patients who are cisplatin ineligible. There's no other trial which has looked at only patients who are cisplatin ineligible. And again, the 2-year DFS was much better, 30 versus 40%, and the overall survival was also much better, 40 versus 50% in favor of docetaxel plus radiation as opposed to going only radiation. So I think with that, we've come to the end of my talk, and I'd be more than happy to take any questions if there are any. Thank you.
Thank you so much, sir, for such an insightful presentation. We have a bunch of questions, sir. So I could read the questions too. The first question is from Avesh Chobe. The question is, what are the possible reasons that few of the people living in area contaminated with medical wastewater develop cancer? Isn't it right to make new laws to treat medical waste to prevent cancer?
I think yes, definitely yes. I definitely agree that environmental pollution is definitely one of the leading causes of cancer. So we talk about the Gangetic belt and why that's, a lot of these industries actually end up emptying all their effluents into that. And which is why there's an increase in biliary tract cancers, especially along the Gangetic belt. So yeah, it is very relevant, especially, if you're looking at, especially if you're looking at people actually emptying industrial effluent waste, is also something that we should definitely look at, and we should come up with stringent laws. But unfortunately, those things which are not in our hands, we can only propagate that. But yeah, I definitely completely agree with what that question that's been put upon.
The next question is from Mr. Vishwajit. I'm working on melanoma skin cancer. What is the scope of research? And he's a bioinformatics student.
So yeah, so melanoma is one of those cancers which has got a very high tumor mutational burden. And we know they're very immunogenic and angiogenic as well, which is why you have a host of mutations happening in melanoma. So it's one of those cases where we do an NGS, and that's where in next generation sequencing, which is where your bioinformatics really comes in handy. So yes, and especially I'm talking about only cutaneous melanomas. But if you're looking at even mucosal melanomas, acral melanomas, lentiginous melanomas, and so on and so forth, I would that probably be only a minority, but so I would probably look at doing it in cutaneous and mucosal melanomas alone. There's a huge host or a number of mutations that can be picked up apart from what we usually routinely check for, which is the BRAF, V600E, and K mutations. We have, especially in mucosal melanomas, we could look at c-KIT. So there's a lot of work as far as NGS and looking at detectable and targetable mutations as well. So definitely, if you're a bioinformatics student and you're into research, yeah, you should look at melanoma. But the only problem with that, in India, it's not very common. Melanoma is not one of those top 10 cancers in India. It's not like, you're in the Western countries or in Australia where melanoma definitely ranks in the top 10. Here, unfortunately, it's very rare to see people developing melanoma.
Thank you, sir. Okay, so the next three questions are from Dr. Avisesh. Okay, so full disclosure, I'm not a medical student, professional, I think so. It's going to be a bit of a challenge for me, but anyway, I'm going to try. The question is a bit lengthy. The question goes like this: how the assessment of the patient with mucositis should include a pain assessment to include thorough review of analgesics used, effect and toxicities, nutritional assessments, quality of life assessment, including screening for depression. Complete oral radiation therapy oncology group describes 5 grades of acute mucositis, like grade 1, grade 2, grade 3, and grade 4. So he's asking, is it fine? So he's explained all the grades, like grade 1 has injection, may experience mild pain, not requiring analgesics. Grade 2 has patchy mucositis, which may produce an inflammatory serosanguinitis, just discharge.
That's okay. No problem. I'll take it from there. That's fine. No problem. No problem. So, when it comes to oral mucositis, I think the first thing that we need to look at is, whether the patient is symptomatic or asymptomatic. So patient has only got mild symptoms, then, we would just put them on, just a mucain gel or any antacid gel, and then put them on local topical application. That should take care of it. But if the patient is symptomatic, has got pain or an ulcer that does not interfere with the oral intake, then that becomes grade 2. But if there is severe pain and causing odynophagia, and if the patient is not able to swallow food and is not able to eat properly, then it becomes grade 3. And grade 4 is when, it becomes very severe enough for us to have life-threatening consequences, where the patient comes in with high fever because of mucositis when the counts are low. Then it becomes grade 4, and grade 5 is obviously death. So, that's how I would look at just simply putting it in a nutshell as to how you would look at grading mucositis. And this is based on the CTCAE, or the Common Toxicity Criteria for Grading of Adverse Events from the NCI, which is what all of us, or most of us use in practice. So you basically look at only basing it on symptoms, pain, and does it interfere with the patient's swallowing, and if the patient has comes to you with febrile neutropenia with severe mucositis needing IV antibiotics and hospitalization, where it becomes grade. So that's how I would put it in a nutshell.
Thank you, doctor. The next question is, what are the side effects of head and neck cancer treatment? I think it's and the special focus on the cases where the lymph node is removed.
So, as far as head and neck cancer treatment is concerned, so most of the times, it is basically, as far as rehabilitation, we call that rehabilitation, when they have to go through Like for example, even if they have a skin flap, it takes time for them to get used to it and for them to actually start swallowing, or the main problem there is when it comes to actually chewing food or swallowing food, and then the saliva secretion and the post radiotherapy complications, like again when you have pooling of secretion, saliva, all of that. I think sometimes erythema as well, and those are the complications which actually need rehabilitation. A lot of people even go through speech therapy as well, because your speech, especially if you have a tongue cancer and if you had surgery, remove part of the tongue, then they have to go through speech therapy for them to go ahead. So, the rehabilitation definitely depends on the type of head and neck cancer and the situation, or the site of the oral cavity cancer as well. So that's as far as the rehabilitation, because remember, treatment includes surgery, chemotherapy, and radiotherapy as well. So all of these can have long-term adverse effects, especially surgery and radiotherapy, where the effects tend to be, lasting for a long time.
Thank you, Doctor. The next question is head and neck cancers.
Yeah, so I think somebody's asked, how can I reduce my risk of developing head and neck cancer? Yeah, so remember that in India, the number one reason is still tobacco, and tobacco, 1, 2, and 3. And after that comes your obesity and all of that. But, if you want to really cut down on your risk of developing head and neck cancer, say a big no to tobacco. Remember the 5 A's and 5 R's of tobacco cessation. Ask, advise, assess, assist, and arrange. And talk about the relevance, risk, rewards, repetitions, and roadblocks. So that's how we look at, trying to get people off tobacco. Remember, it's not just about smoking. It's also about smokeless tobacco, betel nut chewing, or kaini, gutka. All of them are equally hazardous. Don't think it's only about smoking. And remember, secondhand smoking also, passive smoking. So if somebody right next to you is smoking, make sure you're maintaining a safe distance from them. Because remember that you're probably being at much more higher risk than them, because you're inhaling all the harmful carcinogenic substances.
Thank you, Doctor. And Dr. Vistesh, he thanks you for your patient response, and he's also requested your email ID or your contact number.
Yeah, definitely. I'll be more than happy to share that.
Sure. One more, I think this is more like a comment from a person whose question we answered earlier. You answered earlier, sorry. Avesh Chobi, he says, I'm working on medical effluent and anti-neoplastic drug degradation, but there needs to be a law against that so that we can reduce cancer and number of surgery also. Also, I'm keen to learn about more of cancer, neck cancer and cervical cancer, as I have done my analysis on cervical cancer and HPV.
So yeah, I think I completely agree with that. Definitely, we're all looking at framing the guidelines and putting things into context so that we actually bring down the risk of developing cancer as well. Like for example, cervical cancer. Now we have our indigenous own vaccine, which has been manufactured by the Serum Institute of India at Pune. So Cervovac, it costs around 200 to 300 rupees per dose, and it's been made available in most of the government hospitals. So it's being made part of the national immunization schedule as well. So once that happens, all of our kids and children will definitely benefit from that, because you're looking at bringing down the risk of cervical cancer over a period of time, at least over the next decade. So yes, I completely agree with that, and we should have more stringent laws, like I said earlier, about emptying the industrial effluents, especially. So, yeah.
With that, we finished all the questions, sir. I want to take this time again to thank you, Dr. Krupa Shankar and Dr. Sunil Humati, for taking your time and giving us such an insightful and interesting lecture on this important topic and clearing all the questions very patiently. Thank you so much, sir. We've reached almost the end of the webinar. I just have a couple of announcements to make to the participants. So the certificates for this webinar and a feedback form will be sent to your email during the next week. And I'm sure that you found this webinar very informative, and I want to announce that we have one more webinar coming up on 26th of February. The title is Past, Present, and Future of Lung Cancer Management. So we'll share the link as well with you. So we really encourage you to attend this, and I'm leaving the link to the webpage in the chat box. Sorry, just give me a second. So I'm leaving it in the chat box, so you can check out the website, and if you can share it with your networking circle as well for people whom you think it would be useful for. And yes, so thank you all once again. and it was wonderful to interact in this forum. So thank you, IAO and Biolex, for arranging this webinar. Thank you all once again. Have a great rest of the evening. Good night.